Okay, so welcome again, and we move on to the pancreas, the pitfalls that may occur in the pancreas and in the biliary ducts. And I will need your help here because I have difficult cases that I would like to have your help on. And during this talk, we will discuss on biliary tree, and we will analyze, which are the sources of pitfalls that are intraductal, and we will analyze also the sources that are extraductal. And then we'll move to the pancreas, and we will analyze the potential pitfalls that may occur in the pancreatic ducts and in the pancreatic parenchyma. And this, I hope, will help us to be didactic and helpful for your everyday practice. And let's start with the intraductal causes, potential causes of pitfalls. And what I would like to remember here, when we deal with intraductal causes, the common denominator is represented by an endoluminal filling defect. And I'll try to show you to this point. And by doing so, I would like to bring a clinical case, a case that may happen to all of us in our everyday practice. And this is a case of a woman, 67-year-old woman with right upper quadrant abdominal pain. There's a threefold increase in alkaline phosphatase, one-fold increase in transaminase. It's an obese patient, and also she performs sonography, and she has gallstones and mildly dilated bile ducts. So let's imagine this clinical scenario. It's a clinical scenario that in one word is a scenario of a cholestatic patient. With this in mind, the patient did sonography, and so the surgeon wants to know whether there is anything in the bile duct, because sonography was not quite sure about the bile duct. And so we do an MRCP, and in the MRCP, we do see stones in the gallbladder, and we knew it because sonography depicted them, and we see also endoluminal filling defects within the common bile duct. And when we combine this MRCP image with the axial T2 weighted images, we do see this end filling defect, this central dot sign that is typical of a biliary stone. So this is a typical patient with cholestatic pattern. We do a sonography, we do a MR, and we have biliary stones. Which are the signs that are helpful in this diagnosis? On the MRCP is an endoluminal filling defect. And on MR, we have these two signs, which is the target signs that is represented here, but also sometimes, and we will see during this talk, the crescent sign, which is formed like a crescent line. So this is pretty easy. But let's see another case. Let's imagine, same patient, we do the MR, but this is what we obtain. What do we see here? On the MRCP image and this coronal T2 weighted image, we do see, again, endoluminal filling defects. Are these stones? Well, on these images might be difficult, but if we combine these images with the axial T2 weighted image, this is what we see. We do see an air fluid level, because in this patient, a patient had pneumobilia. So I recommend, and this is helpful, so which are the signs that are helpful in the differential diagnosis? On the MRCP, it's a non-dependent endoluminal filling defect. This is also very important because the stone is heavy, so goes adjacent to the dependent wall of the bile ducts, whereas air goes adjacent to the non-dependent wall. And on MR, we have an air fluid level. So the recommendation that I personally follow in these patients, I always perform a plane which is perpendicular to the common bile duct and make me understand which is the dependent wall of the bile duct and which is the non-dependent wall of the bile duct. And this helped me in the differential diagnosis. And let's see this other case. Again, same patient, 67, cholestatic, and this is what you obtain. Is this a stone or this is a pitfall? Well, obviously the answer to the second one, it's a pitfall because this is a half Fourier T2 weighted image, and when we perform the MRCP, this is what we obtain. Where is the filling defect? It's gone. Why is it gone? Because this is not a stone, but this is bile flow artifact. Why is this? On this, which are the signs that are helpful? It occurs, remember, only on half Fourier sequences, not in the other sequences, but mainly on these sequences. It's centrally located, and this is because bile most frequently has laminar flow, so the central part has higher velocity compared to the part which is close to the bile duct walls. And obviously, it's absent in other sequences in which the acquisition plane, it's not perpendicular to the flow within the bile ducts. And this is helpful. I think this is helpful to make a differential diagnosis. Let's see this other case. This is it's not exactly a pitfall, I would say it a differential. This is a patient, again, in which we see a lot of endoluminal filling defects, mainly in the left hepatic duct. When we do the axial, you see in this axial hybrid image, we see a lot of endoluminal filling defects within the left hepatic duct. Are these stones? On these two images, the only thing I would say, it's not the typical location. So I would say, wait a second. Let's do a contrast-enhanced imaging. And this is what happens. In the contrast-enhanced imaging, what we do see here, it's enhancement of this lesion. Because this is not stone, this is an cholangiocarcinoma that has endoductal growth. And this occurs in between 8 and 18% of cases of cholangiocarcinoma. Which are the clues, which are the hints that may help us in the differential? First of all, the endoluminal filling defect is adjacent to the wall because it arises from the wall. Second, most importantly, I would say, has contrast enhancement because it's a neoplastic tissue, so has neovascularity. And the other point, most of the cases have upstream dilatation, and this is because the neoplastic tissue occludes the bile ducts, and there is upstream dilatation, as it is in this case. With this in mind, this is a difficult case. I would like to have your help. Let me show you this example in which we do see some endoluminal filling defects down in the distal third of the common bile duct, and we see here something that is probably an endoluminal filling defect. What do you think this is? Could be a stone, could be pneumobilia, could be hemobilia, could be an IPMN, could be cholangiocarcinoma, or it could be debris. What do you think could be? Please, vote. When we have, obviously, the slide. May we have the slide, please? Oh, here it is. So please, do you think this case that you see on the right, it is the stone, pneumobilia, hemobilia, IPMN, cholangiocarcinoma, or debris? And the answer is cholangiocarcinoma. Very good. I think most of the cases, I don't see it from here, but I can tell more or less 75% of you said cholangiocarcinoma. This is what I also said. But let's go on. This happened in February 2010. Okay? The patient came back, and this happened in December 2010. So 10 months apart. And this is this is the patient. We have an MRCP and an ERCP. And I think you agree with me. Well, the pattern has changed. So I said, wait a second, wait 1 second. What do you think? I don't know what it was. So let me help you. Let me ask your help. What do you think it is? Again, it's stone, pneumobilia, hemobilia, IPMN, cholangiocarcinoma, or debris. Could you please vote? Could you please help me? So again, stones, pneumobilia, hemobilia, cholangiocarcinoma, IPMN, and debris. And can we have the results, please? So, big change. Big change, I agree. So there is a lot of uncertainty, and I share this uncertainty because it was not easy. So, what shall we do? So the patient went back home and was a male. He came back, and this is in February 2011. So this is 1 year apart from the first observation, and this is the images that we did see. So this is a T2 coronal T2 weighted images, axial T1 fat saturated before and after gadolinium enhancement. Would this help? Will this help in our diagnosis? So let's see again. What do you think it is? This was not easy for us, too. I have here a person that can testify this. So what do you think it is? Please vote. Please vote. May we have the slide for the votation, please? Can we have the slide for the votation? Okay, thank you. So here it is. Could you please vote again? So stones, pneumobilia, hemobilia, cholangiocarcinoma, IPMN, and debris. And the answer is... a lot of uncertainty. So we called the pathologist, and he said that the correct answer is IPMN. IPMN. I mean, you can tell from this image, I mean, it was not easy for us too, but that's why I'm presenting it. But in the images that we did in February 2011, there is enhancement. There is enhancement within the bile ducts, within the lumen of the bile duct. And this, I think, it's helpful for the differential diagnosis. And obviously, in retrospect, we are always champions. Let's move on to this other case. This is another patient. There is some clinical history that I will not tell you immediately because otherwise it's too easy. And we do see there is endoluminal filling defect. So, you know, the signal intensity of the distal third of the common bile duct is hypo-intense compared to the upstream ducts. And when we do the axial images, T2 weighted images, what do we see? The crescent sign. This is the crescent sign that I was referring to before. And so this is stone. Could be. But this is when we do the axial T1 weighted images, look what happened. It's hyper-intense on T1 weighted images. In this patient, in which I had also sphincterotomy. Obviously, it's something that I did not tell you before. And this was hemobilia. And which are the clues, which are the signs that are helpful for our differential? And this is the paramagnetic effect on T1 weighted. That means hyperintensity on T1 weighted images that is helpful for the differential diagnosis. And moving on to this next case. This is also, I think, an interesting case. We see this coronal MRCP, in which we do see dilated by intra and extrahepatic ducts, and we do see here the coronal T2 weighted image in which we have, you see it. And what do you think is the most likely diagnosis here? Stones, pneumobilia, again, hemobilia, cholangiocarcinoma, IPMN, and debris. Could you please vote? So, and we are dealing again with endoluminal filling defect. So the answer is there is a lot of uncertainty here, probably because you need the image that is helpful for the diagnosis, and this is the axial T2 weighted image, in which we see this axial T2 weighted image, in which we do see the air fluid level in this patient. Now the diagnosis, I hope it's easy, because this is a case of pneumobilia. Obviously, without giving you, that proves that without giving you the image that make us understand which is the dependent and which is the non-dependent wall of the bile duct might be very difficult. And so this is with the endoductal causes. Let's move on to the extraductal causes. And this, what they cause is stenosis. The common denominator of the extraductal causes is stenosis. And let's see this case of a 75-year-old female with jaundice, no fever, no pain, threefold increase of transaminase, threefold increase of alkaline phosphatase, and she did sonography, and we have dilated intrahepatic ducts, and we perform MRCP, and we do see a stenosis of the common bile duct. And also we have a big appearance of the distalmost part of the bile ducts, and when we combine this information with this coronal T2 weighted image, in which we have thickening of the bile duct wall, enhancement of the bile duct wall, I think the diagnosis is relatively easy as for cholangiocarcinoma. So this is a stenosis cholangiocarcinoma. But let's see this other patient. Is this a cholangiocarcinoma? Well, there are no dilated upstream ducts, so difficult. But what is it? What is this pitfall? This pitfall, it's the crossing of the right hepatic artery at the hepatic hilum, and which causes vascular compression. And this, which are the signs that are helpful for this diagnosis, is lack of upstream dilatation, and it occurs at the hepatic hilum. And so these are helpful to make the diagnosis. I always ask my residents if this is a stenosis or not. But now this is another stenosis. This is another, what do you think? This is a coronal MRCP, then we have an axial T2 weighted, and then we have a coronal T1 weighted fat suppressed after gadolinium chelates administration. What do you think this is the diagnosis here? Is this common bile duct cholangiocarcinoma, gallbladder carcinoma, acute cholecystitis, Maritza syndrome, or chronic cholecystitis? Please vote. Please help me. May we have the votation, please? Thank you. So, common bile duct cholangiocarcinoma, gallbladder carcinoma, acute cholecystitis, Maritza syndrome, or chronic cholecystitis. And the answer is Meritz syndrome? And the answer is correct. Very good, very good. This is what it was, because we have this stone, we do see this stone that is impacted in the gallbladder neck, and this is responsible of fibrosis and stenosis of the common bile duct. So very good, very good. Let's move on, and let's see this other. This is a very interesting case, I think, because this is a patient in which we do see, in the distal third, I would like to focus on the distal third of the common bile duct, and we have the impression that there is an endoluminal filling defect here in the distal third, down here. Then we repeat the MRCP image after a few seconds, and this is what happens. It changed, you see? It changed. We have here, we don't see, first of all, we don't see the endoluminal filling defect anymore. We do have an impression on the other side. This big morphology, we give us the impression that there is a ductal lesion. But when we do the axial T2 weighted images right here, there is no lesion, there is no thickening. So what is it? This is a normal variant. This is the normal sphattering sphincter complex, in which may close, like in this case, or may open, like in this case, like in this face, I mean the same patient. So this is, I would like you to remember that this changes that may occur in the distal third may be due, may be due to a normal anatomic structure. And this is a very interesting case, I think. This is a coronal T2, MRCP, and this is an axial T2 weighted image. What do you think it is? Stone, debris, IPMN, cholangiocarcinoma, ampuloma, or pancreatic cancer? Please help me. So, stone, debris, IPMN, cholangiocarcinoma, ampuloma, or pancreatic cancer. And the answer is ampuloma. Very good, very good. And which are the clues here important for the differential? First of all, on this MRCP, this looks like a stone, but it's not a stone. And what are the two signs? One, there is also dilatation of the Wirsung duct that almost never occurs in case of biliary stone. And when we do contrast-enhanced imaging, this lesion enhances differently from a stone. So the correct diagnosis, as you stated, it's an ampuloma. Well, with this in mind, we move on the other side, that means on the pancreatic side. And we analyze the pancreatic ducts, and we analyze also the pancreatic parenchyma. Let's see this case in which we see signs of chronic pancreatitis that are represented by dilatation of the Wirsung duct, dilatation of side branches, normal size of the Santorini, and endoluminal filling defects that corresponds to these calcified stones on CT, and this was stone in this patient with chronic pancreatitis. But let's see this other patient. This other patient, again, we do see dilatation of the Wirsung duct. We do see endoluminal filling defects. Are these stones in a patient with chronic pancreatitis? Well, the answer is in this T2 weighted image, in which we do see a non-dependent endoluminal filling defect, and in this patient that underwent sphincterotomy, and this is represented by gas. And other causes that maybe represent a pitfall is like this case in which the patient had, this is a coronal MRCP, in which we faintly see the main pancreatic duct here because had extensive necrosis of the pancreatic parenchyma. And this is a case of peripancreatic fluid collection in patient with acute necrotizing pancreatitis. And this may be a source of pitfall because it may hide the pancreatic ductal system anatomy. And this, we cannot avoid it because this is obviously, it is a necrotic tissue within the pancreatic parenchyma. But there are other conditions in which we can do something, like in this patient, in which it's difficult to see the Wirsung duct because there is overlapping fluid from the stomach, and if we give to the patient a negative contrast agent, we can remove this and clearly depict the pancreatic duct anatomy, and this, I think, it's helpful when we have to make a diagnosis on the pancreatic duct system. And let's move on to this last topic, last chapter of this talk, which is the pitfalls that may occur in the pancreatic parenchyma. And this, I would subdivide the potential pitfalls that occur in the head of the pancreas, and this may be solid or fluid. And this is you see solid, annular pancreas, pancreas divisum, paraduodenal pancreatitis, autoimmune pancreatitis, cyst, mesenteric mass, adrenal masses, whereas on the fluid part, we have duodenal duplication, colodocal cyst, and duodenar diverticula. And in order to analyze the pitfalls, let's analyze a clinical case in a patient with jaundice, fever, pain, no fever and pain, increase in transaminase, increase of alkaline phosphatase, increase of amylase and lipase, and increase of tumor markers. Then we do a CT, and we do see an enlarged pancreatic head with a hypodense, hypovascular lesion, and when we do the MRCP, we see the double duct sign in a patient with pancreatic head adenocarcinoma. And this is relatively straightforward. Let's see other potential pitfalls that may occur in this patient in which we do see enlarged pancreatic head of the pancreas, in which we see a centrally located hypovascular lesion, but we do also see stenosis of the lumen of the second portion of the duodenum. Is this a pancreatic adenocarcinoma invading the duodenum? Well, the answer is no. This is an anatomical variant. This is annular pancreas. That means, and which are the hints, which are the clues for the diagnosis, are the presence of pancreatic parenchyma, which is isointense. In other words, tissue that is isointense and isovascular with the pancreatic parenchyma in all around the duodenal wall. And this, the centrally located, is the second portion of the duodenum. So this is a potential pitfall that you should be aware of in anatomical variant. Another potential pitfall is represented by this hypointense lesion in the head of the pancreas on T1 weighted images, and on T2 weighted images, we do see some target appearance. Is this a neoplasm? Well, the answer is no. It's again a pitfall. It's because you see when we do the coronal reconstruction, we see that this lesion, this pancreatic head lesion, is in continuity with the lumen of the second portion of the duodenal and representing a duodenal diverticulum. And other sources of pitfall is represented by this patient, in which we see enlargement of the pancreatic head, whereas the body tail is of normal size. And this is pancreatic adenocarcinoma. Well, the answer is no. This is a case of autoimmune pancreatitis. Which are the clues here for the diagnosis? One, I would say there is no upstream dilatation of the pancreatic duct system. And second, you see the pancreas, there is has more hypodense lesion. We do not see a focal mass, but we see this enlargement and loss of the physiological lobulature of the pancreatic parenchyma. And focal forms of autoimmune pancreatitis in the Verona experience are more or less 56% and mainly located in the head of the pancreas. And I would like to remember, as to a take-home message, If you don't see upstream dilatation of the main pancreatic duct, think, please, at autoimmune pancreatitis. This is why. Because autoimmune pancreatitis is a process from the histological point of view in which we have a lymphoplasmacytic infiltrate all around the main pancreatic duct. So there is a compression of the main pancreatic duct ab extrinsical, like in this patient that we see here, and gives chronic pancreatitis and increase of IgG level. And this is a very interesting case that I would like to have your help on. This is a patient with axial T1 weighted images. We do see here a lesion. And then this is the arterial phase T1, portal venous, and then there is the MRCP. This is a difficult case, I think. What do you think it is? I would like to have your help. Do you think it's a pancreatic adenocarcinoma? Do you think it's a cholangiocarcinoma? Do you think it's a lymphoma? Or a paraduodenal pancreatitis, neuroendocrine neoplasm, or duodenal neoplasm? So please, I would like to have your help, and vote, please. So pancreatic adenocarcinoma, cholangiocarcinoma, lymphoma, paraduodenal pancreatitis, neuroendocrine neoplasm, or duodenal neoplasm. Difficult case. And the answer is very good. Very good. Good job. Good job. And the exact answer is paraduodenal pancreatitis. Paraduodenal pancreatitis, what is it? Ectopic pancreatic cells are located within the wall of the second portion of the duodenum. And this is, I do this to the courtesy of Professor Giuseppe Zamboni from our university. And this is a specimen illustrating the duodenum. And normally these cells, the pancreatic cells, they locate here in duodenal wall. And in patients that are smokers and drinkers, they undergo inflammation and may cause paraduodenal pancreatitis. And this form may have involvement of the groove. The groove is this portion between the pancreatic parenchyma and the duodenum. These forms of paraduodenal pancreatitis may be solid, like the case that I just showed you, but they may be also cystic. And in other words, we do see the cysts within the wall of the duodenum, and these are represented by dilated pancreatic glands and that are inflamed. These two form, the solid and the cystic. We thought at the beginning they were two different entities, whereas in reality we know now today that are the same entity and this is an explanation we had in the same patient that we followed over the years. In 2008 we have a cyst. In May 2000, 3 months apart, there is no cyst anymore, and then the cyst appears again in December 2010. So it's probably the same entity, and according to the entity of the inflammation, may be cystic or solid. When it's cystic, it's easier. When it's solid, it may be more difficult. Other potential pitfalls is represented by this patient, in which we do see a large lesion in the head of the pancreas, hyperintense, with hypovascular. This, however, is not a pancreatic adenocarcinoma, but this was a lymphoma. Which are the clues here? They may help us in the differential. I think that on T2 weighted images, this very high signal intensity is not typical for pancreatic adenocarcinoma, and the sides also is not typical for pancreatic adenocarcinoma. And this should make us think that this might not be a pancreatic adenocarcinoma. And we move to the last topic, in which we have a potential source of pitfalls in the pancreatic tail. And again, I subdivided for you in solid sources and fluid sources. And let's analyze this case. This case number 6, in which we have a 36-year-old female with hypoglycemia. And we do CT, contrast-enhanced CT, and this is what we have. And I would like, please, to have your opinion on this image. Do you think it's a pancreatic adenocarcinoma, splenic artery pseudoaneurysm, neuroendocrine neoplasm, hypervascular metastasis, and intrapancreatic spleen? Please vote. So pancreatic adenocarcinoma, splenic artery pseudoaneurysm, neuroendocrine neoplasm, hypervascular metastasis, intrapancreatic spleen. Please vote. And the answer is very good, very good. Good job, very good, very good. And this is, in fact, a neuroendocrine tumor, neoplasm, and which may be focal, like in this case, but rarely neuroendocrine tumor may be also multifocal, like in this other patient that I'm showing you here, in which she underwent total pancreasectomy because the pancreas was full of neuroendocrine tumor. This patient was operated in 2006 by Professor Bassi from our institution, and it came back last week, and she's perfectly fine, good health, and obviously we are happy for that. But I would like to have your opinion on this other patient, in which we have, again, this is another patient. Two lesions. What do you think it is? Pancreatic adenocarcinoma? Solid splenic artery pseudoaneurysm, neuroendocrine neoplasm, hypervascular metastasis, and intrapancreatic spleen. Please help me. Difficult case. And the answer is not bad. Better than last year. You did better than last year, though. Well, the correct answer, if I may have the slides, is renal cell carcinoma metastasis, but there were hints in these images to make the diagnosis. You see, there are clips, surgical clips, in the right renal, where it was the right renal, the right kidney, and because the patient underwent nephrectomy because of renal cell carcinoma. You did better than last year. Congratulations. So this is last case, the one before last case, and this is again another patient. What do you think it is? Again, let's imagine has hypoglycemia. What do you think it is? A pancreatic adenocarcinoma, splenic artery pseudoaneurysm, neuroendocrine neoplasm, hypervascular metastasis, or intrapancreatic spleen? Please help me. Vote. May we have the voting system, please? Okay, again, pancreatic, do you think it's a pancreatic adenocarcinoma, splenic artery pseudoaneurysm, neuroendocrine neoplasm, hypervascular metastasis, and intrapancreatic spleen? Please, the answer is? Very good. Very good. You were very good. I'll take you home, everybody. Congratulations. Congratulations. Very good. This is what it was. Intrapancreatic spleen. Very good. Very good. And this is my last case, because we are moving from the solid lesion, potential source of pitfalls, to the cystic causes of pitfall. And this, what do you think? Patient did not have any acute pancreatitis. What do you think it is? No, it's dorsally located, it's outside the pancreas, and the patient didn't have any episode of acute pancreatitis. And the correct answer is lymphangioma. Lymphangioma. This is very interesting, I think. What I would like you to remember in this case is that it's dorsally located. This is, I think, in my opinion, it's what I rely on. Why is dorsally located? Because in this other patient, this is another patient, we were able to demonstrate, this is an MRCP, this is a lymphangioma, and we see the connection of this lymphangioma with the thoracic duct, you see, that goes up here. up here. So that's why these lymphangiomas, remember, are dorsally located. So please think of a lymphangioma in this sort of patient. No history of acute pancreatitis and a cystic lesion behind the pancreas. So with this in mind, we reached the conclusion. And I tried to analyze we tried to analyze together the potential source of pitfalls in the biliary tree, subdivided in intraductal causes and extraductal causes. So intraductal, remember, endoluminal filling defect as a common denominator. Extraductal, common denominator, stenosis. Whereas in the pancreatic duct, the same as far as the duct, and in pancreatic parenchyma, remember that other things may mimic a pancreatic solid or cystic tumors. With this in mind, Professor Valerie Vilgren and myself, we would like to thank you very much for attending this session, and see you next year. Thank you. Thank you. Thank you very much.